Today, I'm going to talk about a controversial topic. So I've been getting requests after requests for this topic because it is such a big part of bone health, and it is one that I discuss with my patients on a regular basis. So we decided to bring it all together and shape it in a way where we can really focus our conversation about estrogen and specifically on bone health and in the context of the conversation that we have with our patients. The reason why this is challenging is that when you start to have a conversation around estrogen, there are very strong emotions. There is a ton of fear around breast cancer, fear around blood clots, fear around heart attacks and stroke. There is a lot of confusion. There is a lot of misunderstanding of how hormones are used in the traditional medical space. Different products that are on the market, birth control pills, bioidentical, traditional, patches, pills, pellets. There are so many variables that makes this a very challenging topic to discuss. My goal today is to go through the fear around estrogen, what the research says about that fear, where I feel like it came from, and how over the last 25 years, the opinion on hormone replacement has really changed. I want to talk mostly, though, about the hope of how estrogen and hormone replacement in general, but very specifically in this video, estrogen, and how it can impact a woman's life, potentially a man's life, and what the research says about the potential benefits of estrogen, again, specifically for bone health. So we're going to dig in today on how we consider estrogen as a tool for bone health. And it is an FDA-approved drug specifically for osteoporosis. So we can really say that with confidence that this is something that is available to use. However, it is not often used. And we're going to talk about why, what the research says, how the research, I think, was taken out of context, and how the impact over the last 25 years has really changed how hormones are prescribed. And then in the end, we're going to talk about how we use them, how we have worked our way through the research, and with all the training that I've had in this topic, how we manage estrogen and hormone replacement with minimizing risks, but what risks we do consider to be real and what we do about them. So stick around to the end to really hear the punchline on this, but please listen to the middle part because you'll need the context to understand it. I'll see you then. Okay, so to get into this conversation of estrogen, we really need to understand a little bit of the history. Now, I'm not going to go that far back, but if we go back into the 80s and 90s, this was in a time period where the anti-aging and longevity movement was really picking up speed. And early providers, physicians and non-physicians that were in this space were using hormone and hormone replacement for both men and women, but making some promises that probably didn't hold up to inspection under the lens of research. To be fair, research was not the same 50 years ago and 40 years ago as it is now. We didn't really have the same studies then that we do now. So a lot of the claims that were made off of medications, and then particularly in the natural drug space, things that did not go through FDA approval, they were really made off of very little data. And so there were claims made about hormones, specifically around heart health and prevention of cardiovascular disease, and several studies in the 90s that were published in the 2000s were designed to help to either encourage the use or discourage the use, depending on the bias of the potentially author or institution. But there was a huge shift that occurred in that time. And that's not necessarily a bad thing. As we look at this now, 25 years later, through the lens of fear around the misunderstandings of these research studies. I think research studies like the Women's Health Initiative, which we're going to talk about in detail, but studies like the Women's Health Initiative were designed with an altruistic idea to determine, with a large enough study, is there a benefit from a cardiovascular or heart attack, stroke, blood clot protective pathway, or is there concern of potentially risk, and then also risk of breast cancer and other estrogen sensitive cancers. So big studies needed to be done. These are what were designed in the 90s that came out in the early 2000s that completely changed the face of the way hormones were prescribed. So from a fracture perspective, there's actually pretty reasonable early data that shows that there's a reduction in fracture risk with estrogen use. So if you go back even to 1980, so we're going back 40 plus years to 1980, there were some studies that actually showed in a prospective cohort a 60% reduction in hip and distal radius fractures. That's the wrist, for those that don't know that anatomy. There's another study that I pulled from 1995, almost 10,000 people over 4 years, that showed a 71% reduction in hip fractures and really showed that there was a benefit mostly in that 5 years around menopause. But not all of the data pointed toward a positive outcome with estrogen and bone health. So there was a meta-analysis that we pulled that I want to review, because this is one of the things that I do see cited as the questionable use of estrogen. And people will say, estrogen doesn't always have a positive impact on bones, and they'll cite this study. So I want to go through this one. So this meta-analysis I want to go through is from 2002. So this is right at the same time when multiple other studies that we'll talk about, these big prospective and RCTs on estrogen and hormone replacement, were coming out. But this is a study that looked at kind of like the previous 20 years of studies on estrogen and hormone replacement and how it related to bone mineral density and fracture risk. And again, this is the study that people will cite and say, look, there isn't that big of a benefit. But when you look in the details of this study, and you can look at, all of the studies that they polled, they selected, I think, 6 total studies. And if you look at the 6 total studies, 5 of them show benefit, and actually the numbers look pretty good. So 34% decrease in vertebral fractures, only a 13% decrease in the risk of hip fracture. But what's interesting is that when you look at what's called the confidence interval, and we're going to dig a little bit into statistics here, but when you look at the confidence interval, it actually crosses the number 1, which means that it actually doesn't reach clinical significance. And then there's one that's actually on the other side. And so I'm going to pop up this figure, and what this figure shows, this is figure 1 from this study from Wells, this meta-analysis. And you can see that they actually label it nicely. It says favors HRT on the top, and then on the other side it says favors controls. That'd be placebo and non-HRT. And you can see that there's a study in there that actually shows that it actually favors the opposite when it comes to bone mineral density and fracture risk. So I wanted to dig into this to make sure that I wasn't mistaken in my understanding of the impact of estrogen. So I pulled up this study, and it's by an author named Alexanderson. And what's interesting about this study is that it really wasn't designed to look at HRT. It was actually designed to look at the impact of fluoride on fracture risk. And then I could go through some of the details here, but basically it's a small study, 50 subjects per group, way underpowered to look at fracture risk and arguably also bone mineral density. The HRT dose that they used was very low. They used patches that are really designed for symptom relief from menopause, not necessarily to have enough serum estradiol to have an impact on bones. And they actually only reported a couple of fractures. And so when you look at their data, you can see that there's actually only 2 fractures in the HRT group and 2 fractures in the HRT plus fluoride group, and there's 3 fractures in the placebo group. So I don't know where they came up with the number that they came up with as far as the relative risk. It's not in that study. I couldn't find it anywhere. So I think it's kind of interesting to look at this and to say, well, this one study showed that it actually favored controls, but the truth is that that study really shouldn't have been included, in my opinion, and that they all favored HRT, but they were not clinically significant. So what does that mean? Well, that means that either there isn't an actual benefit, although usually when there's a trend toward a direction and it's very consistent, it likely just means that your study is underpowered. And underpowered means that we just need more people. So when you go back and look at these studies, they were pretty small. We're talking hundreds, maybe a couple thousand people, and also over a short period of time. So I think ultimately what we needed was more people, longer period of time, because we know that fractures, even though I feel like they happen often, when you look at a group of 10,000 people or 100,000 people, there actually aren't that many fractures, especially in a short period of time. It takes a long period of time. So we need big studies in order to prove that these things are either real or not real. And fortunately, we got them, right? So in the 1990s, multiple studies were designed, and these were across the world. So the Women's Health Initiative, which we're going to talk about in detail, the Million Women Study, this happened in the United Kingdom and followed, as it would indicate, 1 million people. PEPI, which is postmenopausal estrogen progestins interventions trial, which is a really interesting trial to talk about. EPAT, which stands for Estrogen in the Prevention of Atherosclerosis trial, and then the HERS and HERS2 trials, which all looked at estrogen and progestins and really tried to find different outcomes to be considered either as primary or secondary endpoints, and ultimately looking at what are the benefits of these things. But like I said, we could talk about this for hours and hours. So I really want to focus on the bone side of things, and the Women's Health Initiative actually did a really good job of doing this. So we're going to dig into that study. Thanks so much for making it to the middle of this video. If you are finding this valuable, please do me a favor, click the subscribe button. If I'm bringing value to you, the easiest thing that costs you absolutely nothing that you can do for me is to click the subscribe button, share this with anybody that you think would benefit from it, and sign up for notifications if you want to know when we put new videos out. If you want to learn more about other tips and tricks that you can do in addition to conversations about other hormones and hormone replacement, look for the link for our free masterclass in the description below. Through that masterclass, we can talk about all those things that I just mentioned. We'll also talk a little bit about our program if you want to learn more about that. If you want to skip that and just talk to our team, there is a link up here in the video. Click that and you can get scheduled to chat with one of our team members. Lastly, if you haven't checked out our book, I have a new book out on Amazon. At least it's new on the time of this video recording, and it should be available on Amazon. And you can click the link in the description below, and that'll take you to our free download page where you can download the ebook, or you can go on Amazon and buy the physical book. I think you might find it really valuable if you have questions about bone health. All right, so let's talk about the Women's Health Initiative. I talk about this study all the time. I want to share as narrow a focus of it as I can with you. Otherwise, again, we can talk about this for hours. If you're not familiar with the Women's Health Initiative, it was a study that was designed in 1991, funded by the NIH, and it included over 160,000 participants. So like I mentioned before, we need a big study. Well, this is a big study. So 160,000 participants, there were 4 randomized controlled trials and 1 prospective observational trial included in all of these 160,000. So they didn't all do the same thing, but they were divided into these different areas. And the 4 prospective randomized control trials included 2 on HRT, hormone replacement therapy, 1 on diet, and 1 on calcium and vitamin D. Now, the reason why they had 2 on HRT and not just 1 is that they wanted to test the estrogen that they used, and I'll talk about that. They wanted to test the estrogen that they used in the study in women without a uterus, so that they did not have to use progesterone, or as they used in the study, progestins. And then they also wanted to show what the risks would be like with those 2 combined, because that's how most women receive it, is if they have a uterus, they need to oppose the estrogen with a progesterone or progestin, as they did in the study. And so they wanted to look at that. So those were 2 different limbs of the study, or 2 different RCTs, as it were. So we're going to talk about one study in detail. And this study was published in 2004 in JAMA, and it says very clearly in the title, effects of conjugated equine estrogen in postmenopausal women with hysterectomy. All right. So in the title, you can clearly see that they used a specific form of estrogen, and they used the same form across all subjects. And this is actually really helpful because it cuts out a lot of question about, what kind of estrogen is going to do what kind of thing. They use the same thing, which is great. Again, good design. The problem I have with this is that there's really 2 components to this. One is that it's an oral estrogen, so it's taken orally, and 2, it's an equine estrogen. And so this is the drug Premarin, and Premarin was very popular in the 80s, 90s, and is actually still used today, and it's made from horse urine. So drugs can be made from all kinds of weird things. Horse urine is a way to get estrogens, and you can synthesize them down. The challenge that I have with this is that it's not particularly natural for the human body. The human body has 3 main estrogens, and horses have 7. So there's some things in there that aren't necessarily natural for humans, but it was something that they could easily synthesize and became very popular as an oral estrogen. So we have to consider that when we look at these results. Secondly, there's a lot of question about what happened in these studies, and there's so much debate as to how these were designed. But let's just assume, for the most part, that these were well-designed studies. I don't want to get into the details of that. But one big takeaway here is that this limb of estrogen only is being compared to estrogen and progestins. And let me talk about that word for a second. So you've probably heard the word progesterone, and I'll do a separate video on progesterone. Progestins are a group or a class of synthetic progesterone. Progestins in this study, not this arm, but the other arm, were used in the form of MPA or medroxyprogesterone acetate, also known as Provera. So Provera was a very popular drug, again, during the time of this, and it is a synthetic progesterone, which is different than micronized progesterone, which is the natural form that you give in bioidentical hormone replacement. So again, progestin, oral estrogen, okay? So one of the challenges I see when people talk about this study is that they say that both randomized control trials were stopped early because they were found to be dangerous. And that's not exactly true. So the oral estrogen and progestin, RCT, was stopped early because there was fear of an increased risk of invasive breast cancer. That's a topic for another day. In the oral estrogen trial, where they were only giving estrogen and not a progestin or progesterone, it was stopped early, although barely. They had 7 years of data. They were planning on stopping it that same year. They stopped it early because their primary endpoint was to see if estrogen alone had an impact on heart disease. And they could see very clearly from the data that had been collected to that point that there was not going to be a significant either increased risk or decreased risk of heart disease in patients that were on the estrogen. So they stopped early because there was no reason to continue the trial. It was not stopped early because of an increased risk of anything, but we're going to talk about what they did find in the results. So of the almost 11,000 women that participated in this trial, there were increased risks of certain things, also decreased risks of certain things. So we're going to talk about strokes, cardiovascular events, blood clots, breast cancer, and fractures. Remember, we're here to talk about fractures, but whenever we're using hormones, we're always having a discussion of risk and benefit. I am not here to tell you that there are not risks. There are risks, but it's clear to understand exactly what those risks are, and then when we have a conversation with a patient, how it relates to those patients. All right, so let's talk about this risk of stroke. So as I've talked about, particularly in my drug videos, drug trials, intervention trials will often use relative risk as compared to absolute risk. A lot of times they don't actually report the absolute risk, but if you haven't seen me define those, you can take a look, particularly in my bisphosphonate discussion. I do a thorough deep dive into that. So the quick version is relative risk is a way to identify the risk, particularly when things are not that common. But when you look at how much the absolute risk is or how clinically relevant that relative risk is, sometimes a relative risk, even of a big number like 60, 70%, isn't actually even clinically relevant, even if it reaches statistical significance. So with stroke, in this study, they showed that the group taking the oral estrogen did have a 39% increased risk of stroke. That sounds like a big number, and it is. When you look at the actual numbers, there were 44 strokes per 10,000 person years in the drug group and 32 in the placebo group. So that means that there were 12 more per 10,000 person years, or 0.12% increase from one group to the other. And that's a small percentage. Is it clinically relevant? Yeah, maybe. I mean, that's 12 people out of 10,000. But it doesn't really matter, and I'm going to tell you why more towards the end. But we don't use oral estrogen, and I'll talk about why. So I would note that this is true, but that we don't actually have to worry about this risk when it comes to how we manage hormone replacement. So the next thing is blood clot, and they describe this as VTE, or venous thromboembolism, and that's a combination of DVT, which is lower extremity blood clot, usually, and PE, which is pulmonary embolism. So lots of acronyms there, but basically blood clot, okay? There were 28 in the oral estrogen group and 21 in the placebo group per 10,000 people years. So that's actually an increase of 0.07%. But when you do the math from a relative risk perspective, it's actually 33%. So again, you can see like really small actual difference, but the relative risk sounds relatively impressive. The thing is that this barely met clinical significance. And again, you can eliminate this risk if you use a different form of estrogen and you get away from oral. Now, here's the big earth-shattering mic drop moment, which is the risk of breast cancer was actually lower in the estrogen group than in the placebo group. I'm going to say it again. The risk of breast cancer, invasive breast cancer, was lower in the estrogen group than in the intervention group. So how is that we have all been told over the last 20 years that estrogen equals breast cancer? It's a long conversation. But to be very clear and very specific about this study, there's a 23% lower risk in the estrogen group. And that is 26 cases versus 33 cases. So again, it's actually 7.07% difference between the groups, but a 23% relative risk reduction in the estrogen group. Now, to be fair, this barely didn't meet clinical significance. So you can't actually claim that it was protective because it didn't meet statistical significance. You probably need more than 10,000 people or a longer time frame to prove that, but it certainly is different than what we're all told. And I think that is a really, really important point. So then you might be wondering, well, how did we learn that breast cancer was caused by estrogen from the Women's Health Initiative? I've been told that over and over again, and I was told that. And you were told that because the other arm, the progestin and estrogen arm, did show an increased risk of invasive breast cancer, although arguably barely, but it did reach clinical significance. And that's why, or rather statistical significance, and that's why they stopped the study early, was because of that. So in the estrogen-only side, there was what looked to be a trend towards protection. Interesting. So what about fracture? Well, there was a 39% relative risk reduction in fracture that was favorable in the estrogen group, meaning that the estrogen group had a statistically significant reduction in fracture risk of 39%. Now, to be fair, I don't want to just talk about the things that I have a bias against in an absolute perspective versus use relative risk for the things that I like fracture reduction. That would be out of integrity. So if you do the math, there were 139 fractures in the estrogen group and 195 in the placebo group. So that's 0.7% decrease in absolute risk, which is statistically significant, strongly, and I think also clinically significant. All right, so just to review that, stroke, there was an increased risk, but I'm going to talk about why that's not actually that important. Same thing with DVT, and that's both of those because it's an oral estrogen versus a different form that we're going to talk about. And then there was breast cancer, which was protective, and then fracture, which was protective. And I guess I should say breast cancer was trending toward being protective, just to be fair. All right, so then how can I say that we don't need to worry about strokes and blood clots? Because clearly those are a big deal. Well, when we talk about the form of estrogen, there is oral, so a capsule. There are topical, there are creams, which is another form of topical. So there was a good study that came out in 2018, actually looking at the difference between oral preparations of estrogen, either with or without progestins, and topical preparations of estrogen with or without progestins. And they also included micronized progesterone. So this was a really great study because it helped me to understand how I would feel most comfortable managing hormones in my practice. And so if you look at the results of this study, they very clearly say that for women using estrogen-only preparations, meaning that they are not using progestins, oral but not transdermal preparations increase VTE risk. And again, that stands for venous thromboembolism. That's blood clot of either one of two kinds. And so again, so that's oral does increase the risk, but not transdermal. And that was statistically significant. In women using opposed estrogens, meaning that they have a progestin or a progesterone on board, there was an important difference between the molecules of progestogen. And progestogen is another way to say both progesterone and progestins. So many words, I'm sorry. So in the transdermal users, in the transdermal estrogen users, there was no change in blood clot risk, I'm quoting that, in blood clot risk in women using micronized progesterone. So I'm going to say that again. In transdermal estrogen users, there was no change in what they say VTE, venous thromboembolism, or blood clot risk in women using micronized progesterone. Strongly clinically significant. And then for women that were using opposed oral estrogen, there was a higher risk in women using MPA, which is what they used in the Women's Health Initiative, which is also known as Provera. And so MPA or Provera with opposed oral estrogens had a higher rate of blood clot than anybody else. And so you go back to the Women's Health Initiative, and you say, well, wait a minute. They were using MPA in the group that they stopped early because of the risk of breast cancer and the risk of blood clots and the risk of stroke and the risk of heart attack, and all those things are true. I would argue that there's a significant chance that it was more due to the progestin that was being used in that trial than the estrogen. And yet that's not the takeaway that most people got from that study. And you could blame all kinds of different people for that, the media, the doctors, the organizations, it doesn't matter. At this point, what we do know is that you can use topical estrogen, you can use micronized progesterone without increasing the risk of blood clot, according to these data. So in conclusion, I want to just reiterate that estrogen is not without risk. I'm not saying it's without risk. However, the risk that is generally associated with estrogen is taken out of context from studies that are probably more attributed, the risk that they show, more attributed to the progestin, the opposition of the estrogen with a synthetic progesterone than the estrogen itself. The risk that is associated with that estrogen from the big studies is coming from the oral application of estrogen and can be avoided or reduced significantly by using a transdermal application, which is exactly what we do. So can I confidently say that estrogen doesn't cause breast cancer? No, I don't think we know the answer to that. And again, there are thousands of studies on this topic. The way I look at it is this, which is breast cancer is a common cancer for women. 1 in 7 women will develop breast cancer in their lifetime. If I put hundreds of women on estrogen, will one of them develop breast cancer? Of course. It's just a statistical fact. It's going to happen. If someone has breast cancer that is estrogen sensitive and we put them on estrogen, will that cancer grow faster? Yes. This is why you have to be careful, and this is why I fear the sort of willy-nilly prescribing of estrogens and testosterones or testosterone without estrogen, without testing, without observation, without physical exam, without continued guidance and monitoring, because they do have potential risks. And I don't think that we should avoid that. But we also need to understand that for someone who has osteoporosis, for someone who is at high risk of fracture, we need to create a program that has all of the tools in it that we can use. And I have so many women in my practice that are so afraid of using estrogen because of the misguided recommendations that have been made over the last 20 years. They are a perfect candidate to use it, and they refuse to use it because they are afraid and they are not improving the way that they could because of that. So we have to understand that we should treat the devil that we know. If you have a high risk of fracture, if you are at high risk of having a hip fracture or spine fracture or another fracture, that is in your face and that is real. If you are at low risk of breast cancer, if you are at low or essentially no risk of blood clot, avoiding estrogen because of those two things, I think is misguided. But this is still a conversation that we have to have with every patient, and it is totally up to them if they want to avoid these things. In my opinion, I think they're missing out on what could be a powerful lever and a powerful tool in their fight against osteoporosis and fracture. So to conclude that, the way that we manage things is with a topical cream of both estradiol and estriol. Why estriol? Conversation for another day. We use testosterone, as I talk about frequently, and testosterone has its own potential benefits on bone health and health otherwise. And then we use a micronized progesterone oral capsule. There are so many forms of hormone replacement out there, everything from birth control, which is not hormone replacement, but birth control, which is commonly used, that I strongly disagree with, all the way down to several different commercial applications. It is such a complex field. So it's challenging to find somebody who I think has a really good grasp on the research. If you are in this space, I would really strongly encourage you to get more than one opinion on what the right approach is. Of course, if you want to learn how we do it, you can visit us on our Masterclass. You can talk to our team and schedule a time to do that. You can also see if our programs are right for you. We have both a self-directed course as well as our full service programs. And that's the end of this video. If you thought that this was helpful, I would love to hear your comments. This is clearly a controversial topic, so I'm sure we're going to get plenty of comments on this, and I welcome them all because, again, my goal and my mission is to help educate, to help people to understand that there is a lot of misconception around these areas, and in particular with hormones, but most certainly around bone health in general. If you found value in this, please do me a favor, like, subscribe, sign up for notifications, and share this with anybody that you think would also benefit from it. And lastly, if you haven't read my book, look for the link in the description below. You can download the free ebook, go to Amazon, buy the book. I really appreciate your comments and reviews on that as well. Thanks again for making it to the end of this somewhat controversial video.